Hybrid minimally invasive esophagectomy for esophageal cancer.
Definition.
Esophageal cancer is among the cancers with the most rapidly increasing incidence in the Western world. Overall survival among patients with esophageal cancer remains poor. The 5-year survival is 10 to 15% among all patients, but increasing to 40% among patients who undergo curative surgery. Improvement in overall survival after esophagectomy have been observed in recent years because of centralization of practice to high-volume centers and the increasing use of treatments involving multiple approaches.
Minimally invasive esophagectomy is performed at Massachusetts General Hospital primarily for patients with esophageal cancer, but is occasionally used in treating benign esophageal conditions. During an esophagectomy, the diseased portion of the esophagus is removed, and the stomach is used to reconstruct the esophagus. Performing the surgery in a minimally invasive fashion allows for a quicker recovery with decreased pain. Minimally invasive esophagectomy begins after the patient receives general anesthesia. The surgeon makes 5 small incisions, known as ports, in the abdomen to perform the laparoscopic portion of the procedure. Using a camera for magnification, instruments are passed through the laparoscopic ports. This process allows the stomach to be moved to replace the esophagus. In cases of esophageal cancer, extensive lymph node dissection is also performed. The portion of the stomach that will be used to reconstruct the esophagus is prepared to move into the chest. The stomach is moved to the chest, replacing the diseased portion of the esophagus. The patient is then turned and the surgeon makes 4 small incisions in the right side of the chest, avoiding spreading of the ribs. The esophagus is removed and the stomach is sewn to the remaining esophagus. Lymph nodes may also be removed at this stage. Following the procedure, the patient is awakened and transferred to the post-anesthesia recovery area. Most patients can expect to stay in the hospital for about 1 week, followed by a recovery period of 4 to 6 weeks. Minimally invasive esophagectomy has been shown to decrease length of hospital stay, diminish pain, and decrease respiratory complications compared to standard open esophagectomy. For more information on the minimally invasive esophagectomy procedure, visit massgeneral.org/MIE.
Application in nursing. Preoperative care for all patients include the treatment of dental, head and neck, or bronchial infection. Tips to keep smoking and drinking alcohol for the least 1 month before surgery, and insertion of an percutaneous gastrectomy tube or jejunostomy for nutrition in malnourished patients. After laparoscopic abdominal examination and confirmation of the tumor, patient underwent minimally invasive esophagectomy.
An operation called an esophagectomy is a treatment to remove abnormal or cancerous cells in the esophagus. Ectomy means to remove. In this operation, part of the esophagus is removed, along with the top part of the stomach and nearby lymph nodes. Lymph nodes capture bacteria, viruses, and other harmful material, including abnormal cells, moving through the body. Typically, the remainder of the stomach is pulled up through the hiatus and attached to the remaining part of the esophagus. Some people appreciate the peace of mind that comes with removing the esophagus. With other treatment options, there is a possibility that cancer can develop in the part of the esophagus underneath the area that was treated. Obviously, cancer cannot develop in a part of the esophagus that has been completely removed, and cancer rarely develops in the remaining esophagus after an esophagectomy. The risks of an esophagectomy in the first month after surgery include infection, bleeding, and leaking from the area where the remaining esophagus is attached to the stomach. As with any major surgery, an esophagectomy carries the risk of death. Typically, medical institutions where surgeons perform a large number of esophagectomies, such as Mayo Clinic, have significantly lower mortality rates than do hospitals where few esophagectomies are performed. After an esophagectomy, food may move more quickly from the stomach into the lower intestine. With certain foods, this can lead to a problem called dumping, causing weakness, sweating, diarrhea, and abrupt tiredness after eating. These effects can be reduced by avoiding foods with high sugar content. Food may also move more slowly after an esophagectomy, leading to reflux or a feeling of fullness in the chest after eating. These effects can be reduced by chewing well, avoiding certain foods, favoring soft foods, eating smaller, more frequent meals, and not eating within 3 hours before bedtime. There are other treatments available for high-grade dysplasia that do not involve removing the esophagus or lymph nodes. Before deciding on any treatment, discuss the risks and benefits with your healthcare provider. Mayo Clinic has a very large team with an international reputation for its skill in diagnosing and treating reflux, Barrett's esophagus, and esophagus cancer. Mayo Clinic's Division of Gastroenterology and Hepatology is recognized as #1 by U.S. News & World Report. If you wish, you may have the opportunity to participate in a clinical trial of a new or improved treatment. Go to mayoclinic.org to find out how to request an appointment with a Mayo Clinic physician.
Pros and cons.
Disadvantage: the patient who underwent open surgery had complications that include preoperative death and major pulmonary complications within 30 days. Advantage: minimally invasive hybrid surgery has associated with a lower incidence of major pulmonary complications in 30 days than open surgery. Also, there was a reduction in surgical trauma, with less postoperative pain and a lower incidence of diaphragmatic spleen and therefore less baseline pulmonary atelectasis. Issues apply in Ecuador. In Ecuador, between 2004 and 2015, gastric cancer has caused a total of 19,115 deaths, of which 10,679 were in men and 8,436 in women. Its occurrence is Jason in the province of Bolívar, Los Ríos, Chimborazo, Tungurahua, and Cotopaxi, which belong to the Sierra.
During an esophagectomy, part of your esophagus is removed, along with the top part of your stomach and nearby lymph nodes. These lymph nodes can capture bacteria, viruses, and other harmful material, including cancer or other abnormal cells moving through your body. Typically, the remainder of your stomach is then pulled up through the opening in your diaphragm, called the hiatus, and attached to the remaining part of the esophagus. An esophagectomy can offer peace of mind because cancer can't develop in a part of the esophagus that's been removed.
Conclusion. Patients after surgery are followed every 6 months for 3 years. Follow includes physical exam, thoracoabdominal computed tomography, and ear, nose, and throat exam, bronchoscopy for ischemous cell cancer.
I would eat, and it would be like my food would get stuck right here. And it wouldn't go, it's like it's not going any farther, and then I'd start vomiting. When I wasn't eating, I was fine. I felt great. Didn't feel anything. But then it got to the point I couldn't swallow water without getting sick. I would literally get sick if I was drinking water. Found out that I was cancerous, esophagus cancer.
The numbers were very scary of how many are diagnosed each year and how many die each year.
I think when patients get diagnosed with esophageal cancer, I think uniformly most of them have this feeling of being lost. They don't know what to do, where to go. They may get online because we are in a technologically advanced age where we are looking everything up on the internet, and what you may find from esophageal cancer is a lot of antiquated data where the outcomes may not be so good. Robotic surgery allows us to do operations on patients that we couldn't do before. So remember, in the past we used to do this operation through a 2-foot incision across your abdomen.
Right.
We are not going to do it that way. What we're going to do is we're going to have several pinky-sized incisions on your abdomen, and we're going to do your entire operation through these incisions on your abdomen. And I've ultimately built a practice to now I have the largest volume robotic esophageal surgeon on the planet. I've done more of these operations than anyone, and it's because of my experience with this that patients have superior outcomes. The patients have less postoperative pain with the smaller incisions. It allows them to take deeper breaths after operations. It decreases their pulmonary-related complications. They're in the hospital less time. I think robotic surgery has really allowed us to do operations that we couldn't before, even with traditional laparoscopic equipment. The one thing that I think robotic esophageal surgery has done for us, has allowed our patients to recover a lot quicker. A lot of the patients that have this operation are out doing their normal activities within 3 to 4 weeks.